Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training.
Series of the dental webinar series where I have two wonderful guests in the house today, one from the University of Illinois in Chicago and another from the University of Michigan in both in the United States. We're going to have speakers from around the world, private practitioners and faculty from dental schools in the United States. Thank you for everyone that is online right now. We have people from Somalia, Nigeria, Ethiopia. I think we have more Ethiopians on today. Thank you so much for coming. I'm going to go ahead and introduce our first speaker. Our first speaker is Dr. Toulouse Foteini. She graduated from Aristotle University in Greece in 2008. She received a specialty certificate in prosthodontics and a master's in dental science from the University of Connecticut in 2014. She became board certified through the American Board of Prosthodontics in 2015. She's a fellow of the American Board of Prosthodontics and a member of the American Dental Education Association. And she's also a member of the American Academy of Fixed Prosthodontics. Dr. Toulouse is currently a clinical assistant professor at the University of Illinois at Chicago. Dr. Foteini Toulouse, thank you so much for your willingness to participate in this series. Welcome to the program.
Well, thank you, Ivo, for having me and for the introduction. I'm going to try to share my screen. Thank you. So today I will be talking about complete dentures. What Uvo didn't mention is that this is one of my favorite subjects because I was teaching in the predoctoral program, Complete Dentures. And we're going to focus on the digital implementation of technology for the fabrication of complete dentures. I kept it nice and short, so hopefully we're going to cover a little bit of the evolution, the history of how we came to use digital technology for complete dentures. I'm going to go step by step over the typical workflow of one of the commercially available systems that in the United States. We're going to discuss about advantages and disadvantages, and then finally I'm going to walk you through a case that we did with one of my undergrad students at University of Illinois at Chicago. This was only a partial digital workflow utilization, but again, you will be able to see how we utilized it. So hopefully by the end of the presentation, I will have provided a basic overview of digital technology for dentures. And hopefully I will have sparked a little bit more the interest in dentures. And then you will know a little bit more about pros and cons of digital dentures and maybe some potential steps for the future. So we're gonna start. CADCAM, a lot of times is a term that it is used interchangeably with digital. I think a few weeks ago, Maria Alfaro covered a lot about this. But I wanted just to remind you that the CAD stands for the computer-aided design, and the CAM portion of the term stands for the computer-aided manufacturing. So essentially utilizing computer softwares to help us design and fabricate our complete denture prosthesis. So in literature, the first time that digital technology was mentioned for the fabrication of complete dentures was back in 1994. A very different old cousin of what we're using now in Japan. And then again in 1997, a group in the same country was able to fabricate the first digital denture, a duplicate denture that was deemed very successful. So in 2013, Bidra had mentioned that in the United States market, there were around 2 available products in the market for the clinician that wanted to utilize digital technology. And then 4 years later, another article mentioned that in the US market, there were around 5 systems that would allow someone to produce a digitally fabricated denture. I suspect that nowadays we have much more. Some of them are only lab systems, laboratory systems. Some of them include a clinical workflow. So there are available different options for both fully digital workflow, apart from the impression making part, and there are also options for utilizing partially digital technology. No matter what workflow you use, no matter what system you use, all of them, the basis of them include 3 steps. The first one is the data acquisition, where you actually gather all this information that we're used to doing even in the conventional workflows. So capture the tissue anatomy, be able to take a CR record, all these things that we all know. The second step is to feed all this information to the computer software and start the design process. Once that's complete, then you move on with the manufacturing of the denture. So let's see how the digital workflow is separated from the conventional workflow. So we all have used the conventional workflow. That's what we are being taught traditionally in dental school. And we know that the conventional workflow requires at least 5 clinical steps, sometimes even more than that, especially when you're teaching some of our undergraduate students. So it can actually extend up to 9, 10 appointments, depending on the case. So the first step always, the clinical appointment, is the diagnosis, the treatment planning. Once you determine that the patient is a good candidate for complete dentures, then you can go ahead and take the diagnostic impressions. You go to the lab, you pull your impressions, either your lab technician does that, and you create your custom tray. That will be then used at the second clinical appointment to capture through border molding the ideal extensions for your final prosthesis. And then you utilize the same tray to take the final impression. Again, back to the lab you go, you pour with stone your master cast, your impression to create your master cast. And on that, you have to have a record base with the wax rim. That will then be utilized in the third clinical step to determine the ideal vertical dimension of occlusion for your prosthesis, take a Facebook record to capture the position of the maxillary arch compared with the terminal hinge axis, and also you take the maxillomandibular record in centric relation. Fourth and fifth appointment, depending on the comfort level of the clinician, they can be combined in one trine, where you have the option to make changes in the tooth setup and communicate with your patient what they're expecting to receive at the next appointment, which would be the delivery of the prosthesis. Now, all of that, the digital workflow claims to be able to do in just 2 appointments, ideally. The first appointment will be the one that you cover all this information that you need. So in one appointment, you combine the first 3 clinical appointments of the conventional workflow. If you want, you can have an intermediate appointment for a trial denture appointment, see if everything goes well, and then you can move on with the delivery. Let's see now how this is done step by step, utilizing as an example the workflow by Ivoclar, the protocol for the Wieland digital denture. I use that just because I had some experience with it, and also there's a lot of material available online that you can review. So for the first appointment, you have to bring your patient, do a full intraoral exam, and then once you know that you're going for complete dentures and you decide to utilize the digital technology, the first step is very similar to the conventional technique. So you're going to have to start with your impressions. Different digital workflow, different systems actually allow the clinician to have some, leeway there with how they want to make their impressions. You can either utilize the simple old alginate, or you can go to what we normally do as a final impression, utilize a custom tray and PVS material, border mold your tray, and take a wash impression. A third option would be to do an intraoral scanning of the soft tissue. This is actually at this point not very widely used, and that's primarily because the intraoral scanning of the edentulous ridges is very problematic. Number one, it's very difficult for a clinician without having any fingers to capture the tissues and create an accurate image. And number two, it's very difficult to discern the different types of mucosa that is available intraorally. So still, this is a problematic impression making with the intraoral scanners, although there are some hopeful articles and reports, like the one by Goodacre in 2018, but there's still some room there for improvement. So once you complete your impression making, then the second step would be to move on with capturing the ideal vertical dimension and take your CR record. Different systems commercially available have different options, and they provide you with some instrumentation for that step. I think that's the most critical step. So the Wieland digital dentures are utilizing what you see on the picture. It's a centric tray, as they call it. Essentially, it's a glorified triple tray. The same way you can use for a single crown impression, you can utilize it for the edentulous ridges. The way you use it, you place putty, PVS material on both sides of the tray, and then you have essentially your patient bite on it, make sure that you capture enough of the ridges so that it's relatively stable, and then you guide your patient in CR, in centric relation position, in the predetermined ideal vertical dimension that you determined. The next step would be to do a modified phasebow transfer. This type of phasebow is compatible with this workflow. It's called UTS CAD because it's utilized in the computer-aided design of the denture. It slides inside the centric tray, and you can record two measurements, one for the interpupillary line and one for the Camper's plane, for your occlusal plane. All this information now that it's complete can be sent off to a laboratory that will enter all this in the lab scanner, and we'll be able to move on with the start of the design process. What you see here is the system by Avadent. I wasn't able to find something for the design of the Wieland dentures through Ivoclar. So you can see how the lab technician that utilizes the digital workflow can easily identify anatomic landmarks that could help you later set the teeth based on all the classical principles that we know for denture making. But one of the most important things that I see in this workflow is the ability to trim the model. So instead of having an overextended final denture that will then translate to many more adjustment appointments, at this stage you can easily identify how far you want your denture to be extended by simply trimming the model. So once this design has been approved by the clinician and you have finished all the denture setup and all that, you can go ahead with the manufacturing of your denture. Right now, two techniques are available out there for the CAM part of the process. The first one is the additive manufacturing. An example of that is rapid prototyping. This is what actually was used in that first denture that was fabricated in 1994 back in Japan. And it looks something like what you see in the screen before it's actually final. The second and most used procedure is the subtractive manufacturing, or milling as we call it. So let's see how these look like when we actually utilize them. So for the rapid prototyping, you have additions of layers of resin that it's photocured actually. And the final product for the base will look something like what you will see in a few seconds. And the sockets are already on this base. So the teeth will also be manufactured this way and be luted on the base. For the subtractive manufacturing, you're going to have a pre-polymerized block of acrylic, like what you see in the video. And then the mill will go ahead and essentially remove whatever does not belong in your design. This way, you will have no porosity of the final product, and you will have no shrinkage of the final product, as there's no real processing happening. In a similar way, the teeth will be milled as a block and eventually be luted on the base. And I'll be showing you a little bit later how does that work. So once this process is complete, the clinician has the option to either go for a trial denture or just go straight to delivery. Now, till recently, the companies, when the clinician would ask for a try-in, they would provide something like this. You can see that this is a very problematic try-in because it's very hard to communicate with your patient how the final denture would look like. Patients cannot imagine where the gum tissue will stop, where the tooth will start. So it was very difficult to allow for the proper communication between patient and clinician. Now, companies, luckily, they heard the complaints and they came up with another option for trying. You can have a two-colored, pink for the tissues, white for the teeth type of prosthesis, very roughly made. The option is either to go monolithic, so one piece with two different colors, or you can have a printed base with just milled teeth attached to it. Obviously, you can see that the quality of this trying is very rough. It could never pass as a final prosthesis, but at least serves the purpose. So once you review the trying and you determine if you want changes or not, the manufacturing of the final prosthesis can be completed. And then you can have something that looks like this, which actually looks very good. And it's very similar to what we're used to seeing with the conventional methods of processing complete dentures. So we do know a lot about the conventional processing of dentures, the conventional workflow, and we know the good and the bad stuff. We know that the good thing is that we know it. It's something that we've been doing for years and it works well. But we also know that there's certain limitations. One of them being the number of appointments needed, which also translate to clinical chairside time, which then translates to increased cost for the patient because of the clinician's time that it spent. If you want to change something on the lab work that you receive from the lab, then that would mean additional expenses and also additional time for the processing. So something that could be completed in 5 appointments, it might end up being 6, 7, 8 with the additional lab turnaround time. Also, we know that the CADCAM methods, the traditional methods of processing dentures, they have certain concerns. One of them being, the biggest one being the shrinkage that you expect to have from the acrylic with the traditional methods of processing. Also, another one would be the porosity because of the remaining monomer in the material. Finally, even if you get that perfect denture with the traditional methods, if the patient comes back in 1 week because they lost it or the dog ate it, then you won't be able to reproduce the exact result. So that's another shortcoming of the conventional workflow. Now, can CADCAM or digital denture overcome all these issues? Let's see what literature says. Number one, the Goodacre group has done extensive research on this subject. They have published something, an in vitro study that was looking into the adaptation of the denture base only for the maxillary arch with different methods of processing, one being the digital and milled denture. So a pre-polymerized block being milled to become a denture versus all the conventional techniques. What they found was that the CADCAM denture had the most consistent adaptation on the cast that they had used. So that's very good. There are a lot of research out there that shows that they do actually fit better than the conventional dentures. The next article that I am showing you here, it's a systematic review by the same group that, interestingly enough, they have utilized the digital workflow in preclinical, in pre-doctoral clinics as well. And they found that a lot of complications that patients and clinicians were complaining about with digital workflow could have been avoided by utilizing an additional 3rd appointment for the trial denture. So most times clinicians and patients were asking remakes of the prosthesis because of aesthetic concerns and because of ill-fitting denture. So both of these could have been addressed at the trying denture stage. An article by Toulouse, published in 2017, discussed the review of digital impression techniques, and they found that Intraoral scanning is problematic, as I mentioned earlier, for the reasons being the difficulty of capturing accurately the edentulous ridges. And the second thing that they noticed is that articulations, so essentially how the teeth come together with the functional movements of the mandible, was very problematic in the digital workflow. I will say that since then, and based on my limited experience, I've noticed that things are not looking as bad, with the digital dentures that I have delivered being, very similar to what you would expect with a conventional denture. Certain adjustments need to be made, but not anything excessive. Lastly, a clinical study by the Yukon group, they produced 2-visit CADCAM monolithic complete dentures, and they found it being a viable clinical option, but they urged the clinician to carefully choose the patient that they're going to use. If you see a patient that comes in with 15 dentures in a bag, or if they are very exacting on the way they want the aesthetics to look like, maybe that's not the patient that you want to go with a 2-visit denture. And then secondly, they noticed that they ended up spending more time for the fabrication process. That time includes the communication with the lab technician. What is worth mentioning is that the clinicians used in this article, they had only done another digital denture, and additionally, the workflows have changed tremendously since this study. So everything is a little bit more user-friendly. So a few of the disadvantages that have been mentioned in the literature. Lots of people discuss the fact that the cost for the implementation and the maintenance of the equipment is very high. The more companies, though, that produce this type of equipment, the less is the cost of this type of equipment. So I think it's worth investing one time in this type of technology. There is a learning curve, as with everything in dentistry. Whenever we initiate a new technique and we utilize a new protocol, it's expected that it will take a few tries until you feel confident in the technique and you troubleshoot. One of the issues that clinicians very often bring up is that during this first appointment, where you are expected to gather all the information needed to move on to the design step, so identifying the appropriate vertical dimension, recording the centric relation between maxillary and mandibular arch, identifying the appropriate lip support or the incisal edge position. It's very challenging with the devices that are sent by the different companies. So that is true, but as I mentioned before, there is always the option, at the additional cost, of course, of having a trial denture stage. So instead of 2 appointments, you can add the trial denture so that you potentially could fix some of the issues with all the above mentioned. Finally, a lot of clinicians and patients, again, complained about the lack of a trial denture, but since then the companies have provided the option of having a try-in for a denture. Now, in my opinion, the advantages outweigh the disadvantages, and there are a few. The biggest one being the reduced number of patient visits, especially when we're talking about the elderly population, that is primarily the population seeking complete dentures, although not exclusively, since right now we have a lot of patients needing all-on-4s, where part of the process includes the fabrication of a denture. So the big advantage is the minimum amount of appointments needed. The second biggest advantage is the fact that the final product, it has superior strength and fit than what the conventional fabrication methods would produce. Also, we have a final product, especially with the mill type of manufacturing, that is less porous. Less porosity means less harboring of bacteria, which then translates to less chances of having infection of the tissue, denture stomatitis that a lot of times see in our patients. Reduced time and reduced number of visits translates in reduced cost for the patient and clinician. As I mentioned, with the complete dentures fabricated through the digital workflow, you can create a digital file. So in worst case scenario where the patient loses their denture, or they just want a spare one, or you want to make one just for a surgical stent, you can just easily produce one with the push of a button. Obviously, this allows for you to have multiple same exactly prostheses, which then allows for better quality control and more standardized clinical research. And then finally, something that definitely will help dental students all around the world and prosthodontists is the fact that with a click of a button on the computer software, you can develop the ideal occlusal scheme. At least theoretically, it's much more easy than moving teeth on wax. So we covered a lot about the digital workflows and the dentures. I am now going to show you step by step how we implemented partially digital workflow for the laboratory part of the process in the undergraduate clinic at UIC. Our fourth-year dental student actually presented on this in the clinic research day in the institution, and since then he's a clinician out there. So let me walk you through the process step by step. So this is our patient. She was happily dentulous, as you can see, and her tongue was taken over. So we had to deal with that. But we did do at the first visit, we did do a full intraoral exam, and we identified her as a good candidate for complete dentures, and we decided to try the digital workflow. So at the end of that appointment, we went ahead and we took 2 alternate impressions with appropriate extensions. The student utilized the conventional methods, poured with stone the diagnostic impressions, and fabricated the diagnostic casts. We outlined the ideal extensions, and here is where we actually took a different route compared with the conventional workflow. He created the custom trays out of Triad with the appropriate extension, but he also incorporated wax rims, and not actually wax rims, but Triad occlusal rims. This way, if we had to send them out to the lab, as we had to, the wax would not distort. So we utilized this modified custom tray and record base to first take a final impression. So we bored and molded, and then we took a wash impression with a PVS material. Now the occlusal rims were much more stable inside the mouth and allowed the student to take a much more accurate centric relation record. You will also notice that on the maxillary occlusal rim, we identified the midline, the high smile line, and the position, the ideal position of the prosthetic canines, the way you similarly do for any conventional denture. All this information was then shipped to the lab, where they used the lab scanner to upload all this information with a technique named reverse engineering. And now we could have a digital preview of the tissues, the teeth, and the setup that we wanted to have. Once we approved the initial design, we ordered a trial denture that we had the chance to intraorally check in our patient. We had the ability to communicate with her what we are hoping to do with the final restoration. We also identified at this stage that the occlusal plane was a little bit higher than we ideally would want. So we chose to send it back to the lab, ask for an updated digital preview, moving the occlusal plane a little bit closer to the mandibular ridge. Once we saw the digital preview, we felt very confident to go ahead with the fabrication of the final prosthesis without a second trying. So the laboratory technician fed essentially the milling unit, which looks something like that. This is just an example out there by the same company, Ivoclar. And he loaded the milling unit with a white-colored pre-polymerized block, or pack as we call it, for the fabrication of the teeth in one block, and then a second pink block pack for the fabrication of the base. Now, how these two come together, the denture base is roughly initially milled with the sockets milled out as well. The block of the teeth is also milled. Then the technician will lute them together with a liquid type of resin and return the whole block back in the milling unit to finalize the processing, so that the final denture looks actually very nicely finished, without having this transition between teeth and denture base. Once the denture is complete, is shipped out to us, and you can see that the final product looks very good. The patient at least was ecstatic with the result, okay? Obviously there are things that we can improve on the aesthetics, but I think she was very happy, especially because of the minimum amount spent in the dental chair within the dental school. So we saw what the digital workflow is capable of doing, but there are some room for improvement. So first and foremost, the ability to intraorally scan the tissues accurately for the fabrication of a complete denture would move us very fast ahead. That's because it would truly turn the workflow into fully digital, removing the conventional part of the impression making. That would also minimize the amount of laboratory turnaround time, because you just, with the push of the button, you can send the scan as an STL file to the laboratory tech that can then start immediately the design process. The second thing that we might need to work on is to identify a more aesthetic way to create the final product. Still, I think a conventional denture fabricated by a talented lab technician, custom made to the patient, would probably look better than what we normally see by the digital workflow. Then what I'm hoping to see personally and as an educator is to utilize more in the pre-doctoral programs the digital workflow. I think that dentures a lot of times get a very bad reputation because they seem to be one of the most tedious and multi-step procedures within the dental school. So I think lots of students tend to not like them. I think utilizing digital workflows and softwares will make it much more interesting for the dental students. And then finally, if we manage to make the workflow more widely applicable and we lower a little bit the costs, the potential use for the public health is tremendous, in the sense that we can now go out with the scanner and then within 2 appointments be able to provide underserved populations with complete dentures, when previously they wouldn't even have access to a dentist or to this type of procedures. And that completes my presentation, and thank you for your attention. And I think you might have questions.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator